Good afternoon to all. First of all, my respect and regards to Dr. Manoj Chawla sir and Purvi madam, not only for inviting me here, but also for promoting me from a diabetologist to a debatologist. So thanks for that. So people are now recognizing me more as a debatologist. So we start with that. And the way she talked, I just thought that she would ring up Brihan Mumbai Municipal Corporation to mix up SGLT inhibitors in the water so that they can be circulated. And she will also go home to give some injections like influenza vaccine because most are injectables. Thank God she didn't do that. She stopped before that. So it's always good to oppose a motion because you act like a public prosecutor. You can just blast off saying anything, but first of all, I recognize she's a good friend. But as science is concerned, I must puncture all those things which she has inflated in the balloon. So I appreciate my opponent for a great work-life balance. She dances so well. I'm a great fan of that. But today we will only be talking about science. I was pretty confused why she chose the wrong side to choose to defend. We are ruined today by a problem of plenty. As she told, we have a lot of drugs now. So you go to a sari shop and she will also get confused which one to buy. The same thing happens when we write a prescription. But the choice of medicines have to be scientific and trimmed to the need of the patient. Otherwise, hope becomes hype and boon becomes a bane. Highlight of the title, let us look into that. The term always, it's a very exclusivist term and it removes clinical judgment. Then you invoke AI, you just put in the data, it will churn out prescriptions. There is no point in thinking. And before insulin, this term is very important because many patient has need for insulin. And the dictum is where insulin is required, it has to be given. Think of excess sugars, HbA1c of 13. Think of pregnancy in diabetes. Think of DKA. Think of early onset type 2 diabetes. Will you give? Of course, where insulin is required, it has to be given. Now I want to press charges against her on the 4 points. That is, she has fired a misdirected missile. She forgot the main work of glycemic control. She is promoting a coup like dethroning the king, which is insulin. So maybe UAPA may be applied against her. Crowning the wrong candidate because not fit for the entire job as a whole. Why I will elucidate. And promoting nepotism. When you are in Bollywood, you must be talking of nepotism. So I'll cover all these points. So I pray whatever she said, my lordships, some restraining or gag order should be applied to whatever she has said so that we can discuss at the end. First point, this is a real problem. We all have become very much tunnel vision. Whenever you see a diabetic patient, we assume there will be CKD, there will be CVD, there will be heart failure. In our garden variety of patients, many patients do not have so. So I don't believe in bekar fear mongering. They may not be having those problems at the outset. So jolly well you can give some other drugs. And when required, insulin has to be given. We need to remember that we need to treat hyperglycemia properly because this is the utterly deplorable circumstance that we're having in India, that 8 out of 10 have uncontrolled hyperglycemia and 2% higher average HbA1c levels we see in our patients. Let us turn to the Bhishma Pitamaha of our diabetic studies, that is UKPDS, and I quote one article from some of our friends and teachers. We learned many things from there. Number one, the legacy effect, and number two, if you do good glycemic control, it can bring down the microvascular complication rate. And there is no point overemphasizing that every 1% reduction of HbA1c can give a myriad of benefits, which you see in all slides. So glucocentric to holistic is okay, but that doesn't make it to be unholy by forgetting glucose control. If you still do not prioritize sugar control and talk only about the fringe benefits, it will be like a naughty cameraman who is focusing more on the periphery of the field rather than what is happening in the middle of the field. See, Virat Kohli is angry, and so am I. Second is promoting a coup. He's trying to dethrone the king, that is insulin. We need molecules with good efficacy. Now, HbA1c of 14.5, fasting of 200, PP of 345. What are the average reduction values for SGLT2 and GLP1? These are the values, very poor values. Let us look at insulin. It can be very high. From any HbA1c, you can actually bring down the HbA1c to a particular limit. Second point is glucotoxicity amelioration. We have studies to show that beta cell rest can actually rejuvenate the pancreas for some time and it can act for some time. So that part is important, that facilitating beta cell rest is an important concept, though there are debates about it, but still I hinge on to that idea. Also, if you put on more than 3 OADs, not much to gain. So it is like when you invest in mutual funds, we always, any business, it is return on investment, ROI. So it is actually following the law of diminishing returns. So that part also has to be remembered. And that circumstance is where you are failing with other drugs. You need to introduce insulin, likely basal insulin, because that can be given once a day. Third point is crowning the wrong candidate, not fit for the entire job. Let us look at the deficiencies. Obviously, I think these molecules are getting too much attention in the spotlight. I was just going through some meta-analysis and collected this data that all these studies, Empire, Canvas, Declarative, Credence, DAPA-HF, most 74% of patients in each CVOT trial receive metformin as a part of standard of care. That means the baseline, like mother does, is there. Above that, you are giving in one placebo, in one SGLT2 or IMDs. I'm not saying that this is taking away the chunk of benefits what the SGLT2 inhibitors gives. Obviously, they're beneficial. That's why they're approved. But what I need to say is that metformin was already doing its job from the baseline. So it was piggybacking on metformin. In almost all the studies, metformin was there at the baseline. Regarding CV risk reduction, she said very well, I also accept that these molecules do reduce CV risk, but metformin also goes strong. If you look at the SOC standard of care diabetes, I'm just quoting from there, that metformin is effective, safe, reduces risk of microvascular complications, CV events and death. What more can you expect from a cheap molecule like metformin? And also, falling back to UK periods, overweight patients, 33% reduction in 10 years for MI in the metformin group. And when they were followed up for 10 years, that benefit remained and sustained. Regarding heart failure, obviously we have a myriad of studies. I will just skip this slide. So sugar reduction is important, whichever molecule you use. Why did I say so? Because this is another meta-analysis where they showed, this is a summary, that in CVOTs, only tighter glucose control by 0.9% could have translated to cut down CV events by another 33% more. So only sugar control by whatever resource you have at your disposal can actually do the wonders. Lastly, SGLT inhibitors not very much superior even in body weight reduction, because we see that is the reason why it could not be promoted as a weight loss drug, because it is a ceiling effect beyond which it doesn't work, and in some patients it doesn't work at all. If you look at the trajectories of kidney function, I picked up this. If you look at fourth point, the wavering serpentine line in non-proteinuric, non-albuminuric DKD. I just put this meta-analysis. It's a very busy slide, but what it shows is if the proteinuria is more, the benefit is more. If the proteinuria is less than 30 or below 300, the action is less. So it doesn't work uniformly well in all the groups. That part has to be understood. Why did I say so? I'll come to that. There was an article published very recently in JHA. These authors were hell bent upon to extricate some benefits from SGLT2 inhibitors in low risk group population. So they divided into less than 65, more than 65, regarding all cause mortality, CV death, hospitalization for heart failure, stroke, etc. But they could not find out anything. See what they concluded themselves. It says that SGLT2 inhibitors confers a similar risk for all cause mortality and CV and renal events as those with metformin. That means metformin is as good or as bad as SGLT2 inhibitor if the patient is a low risk, which is almost 50 to 60% of the population that we handle in the peripheries. And they explained the reason that the cardiovascular benefits of HL inhibitors could possibly be offset by the inferiority of glycemic control compared to metformin. So this point also has to be remembered. Now problems, they create more tantrums than actually benefits. Have you ever seen any lactic acidosis in your life? But you have definitely seen a lot of GMIs, UTIs, GI issues. So SGLT2 is a tough pill to digest, and IMD obviously a rough road to navigate. Last point, when you talk of Bollywood, there will be nepotism. So it's good for photo op, page 3 stories, but we need to understand they're beneficial in select group of patients, not in all types of patients. They are star children from fancy club. They need not be given in all patients. They can be given in select group of patients. For example, A1C of 10 with Flozin IMD on board. Any benefit can be accrued? I don't believe so. First, you have to look at the sugar control. So these two things have to be balanced. Lastly, again from Mahabharata, Karna had once asked Tatshri that why do I always suffer still on the right side of life? He said that you are a trusted, tested and tried friend of Duryodhana. Only problem is you are on the wrong side of dharma. The problem with insulin maybe it's injectable. That is the only problem it's facing. Otherwise, it should have been on board. And cost, I think Shubhasri just treats these sorts of patients. That is why she is not concerned about cost. So lastly, this is my last slide, that you may fall in love and fall out of love many times from your puberty till you get married, but ultimately you get stability in life. That is what you want to achieve. So when you were treating diabetes, similarly, you may fall in love with pioglitazone. Then you said, okay, in 2006, gliptins have come. Then in EMPEREX study, okay, SGLT2s have come. Now you are just going gaga with the tides, semaglutide and tirzepatide. But ultimate thing is the HbA1c and CGM stability of the patient you are handling. So my word is, feelings may fade, but purpose is forever. So I rest my case saying the right drug, right time, and right patient will give the best of care. Thank you.